Hi, this is the second part of temporomandibular disorder among women. Uh, I am Dr. Bill Wyatt. I'm a general dentist and I've practiced only orthodontics for the past, since 1970. That's over 40 years. And I'm a member of the American Orthodontic Society. Now, this is a society of general and pediatric dentists whose primary purpose is teaching orthodontics to general and pediatric dentists, or really any other dentist, specialty, whatever, that wants to learn orthodontics. We have an excellent organization. We have our own journal. We have our annual meetings. We have board certification that you work up through steps to learn and pass the American Orthodontic Society boards. And if you can pass these boards, you can doggone sure do orthodontics. So we feel like it's very important that people who join this organization try to work on passing the orthodontic boards. I feel like this is really necessary. It's going to be even more necessary in the future. All right, so much for that, and let's get on to this problem with TMJ disorders among women. Now, there's about 80% of your TMJ cases will be women and about 20% men. It's somewhere around that. It just works out that way. We don't really know why women have more problem with it than men. It's not because they might talk more, anything like that. So we don't really understand. Now we're showing 3 cases in this whole thing, and this deal will have to, let me get this where I can change it. Now, I took this case in right here. I worked for 25, maybe close to 30 years with a Dr. Charles Holt. Now, Dr. Holt did nothing but temporomandibular work, and his whole practice was that. And he saw a tremendous number of cases. Now, he would get them comfortable on the splint. Now, I mean, this is just a plastic splint. You take an impression of the teeth, you make a base shell, and then you put soft acrylic on it, but you have to fit it and everything and adjust the person's mouth. And some people use these mile monitors and different things to locate the jaw. I never did care for those things. I could take a patient and just set them down in the chair and let them relax, and you talk to them, you tell them what you're trying to do, and let them just lightly open and close their mouth. And if you want to test this out, you can just try it yourself. I've tried this on whole audiences of people. If you just relax and sit with your head in a proper position, a normal position where you hold your head, and just relax your jaw and let it open and close, but don't touch your teeth. Just get right there close to them. If you do touch them, don't put any pressure, just open and close, and your jaw in nearly all cases will go to where it wants to go. And then when you get to touching your teeth and you go to bite tooth, many people will slide backwards or slide distal, and so we call that a distal slide. And of course, as you slide distal, the head of the condyle, that's not a very good condyle, but is being the fossa right here, the condyle will move backwards. Now, frequently when the condyle is back in this area, of the fossa right in here, or it crowds the retrodiscal tissue, and your ear is right back in here too, see? And you crowd the retrodiscal tissue. This is where all the blood vessels and the nerves and everything are. Actually, on the strap, or what we call the disc, coming across in this area, there are no nerve endings, nerve vessels, and no blood vessels and no nerves in this area. There's so much pressure on this area, so they just can't form in there. So this tissue in this area, or what do we call it, a disc, it's kind of silly, it's an actual strap coming across there, and it's attached everywhere. This strap takes a tremendous amount of pressure out here. If you run your jaw on out to the front, like such, and you put pressure out in here, and the muscles are in here. In other words, you put 10 pounds of pressure in the front part of the jaw, and the muscle is pulling right back here in front of the condyle. This part right in here may be taken, if this is 10 pounds, this may be 20 or 25 pounds of pressure back here. So it takes that strap takes a tremendous amount of pressure, and that's where things go wrong. Now, if you get bumped in the jaw, or your jaw is tending to slide back when you chew, then you tend to slide further back in this area, and that irritates the blood vessels and nerves back here where the synovial fluid is made. You say, well, how does this tissue right in this area get fed? Well, it gets fed by having this synovial fluid carries oxygen and food in, and as you bite down lightly, just tapping your teeth or chewing very easily, pushes this liquid down into these cells, and that's the way they get fed, and they carry off the waste product and take it back out, and the blood system picks it up. The temporomandibular joint is a complicated joint. I'm going to erase this. This looks too confusing right there. It is a very, very complicated joint. And like we used to when we did surgery, they would wire the jaws together. In other words, the condyle would be in the fossa in a certain position. I'm sorry, I have to get that thing going. The condyle will be in a certain position, and the strap would be pressed up underneath here under pressure, and leave it that way for 4, 5, 6 weeks or something like that while the jaw healed up, while you healed or you fixed a broken spot in the jaw, where you shorten it or lengthen it, depends. But if you kept this thing wired together, then there couldn't be no food get to this part of the strap. And so the strap, I've talked to old surgeons, would go in there with, this thing is so tough, it can stand all this pressure, yet after sitting under just starving for 4, 5, 6 months there, this tough tissue could just be raked off like cheese. In other words, you just ruin the disc or the strap that went between the condyle and the fossa in here. So anyway, I'm going to try to put in a little bit of stuff on the TMJ as we go along with these, and you kind of help you understand it. It takes a while to really understand temporomandibular joint problems. It is not a single cause. I don't believe I've ever treated one that was just nothing but this or that. Your tension puts a tremendous load on this thing. The stress is very harmful to it. A blow to it if you hit the jaw, that's why you see there's not very much room between there and the brain up here, and you got your ear right over here, and you get hit in the jaw, and it drives this thing back up here and knocks the person out. So it's a real vulnerable part of the body and can be hurt very bad. My little niece was playing basketball, and somebody came by her and hit her in the jaw with her elbow. Well, it jammed this thing up and just really gave her a fit, and for several years she had trouble with this jaw joint where it was knocked like that. So this just gives you some idea of what can happen in there. All right, so we get somebody in and they're having trouble. The vast majority of the people, I'm going to take this out just for a minute where I can draw this thing. Say your fossa is, this will be a crude illustration of it, and the condyle really should be up in here somewhere around. I'm not saying because it's different for everybody, but not totally different, you know, and your jaw would come on down here and come out, and you have your teeth and stuff. And there. Now, this area, that's not going to be exactly like that. This is where your retrodiscal tissue is. In other words, you've got a lot of blood vessels and nerves in here. I'm just be simple with this thing and get every dentist to understand, because every dentist needs to understand a good bit about the temporomandibular joint, because you can put a filling in wrong. You can put a crown in and make it thick and shove the jaw backwards, and they'll have trouble, or a lot of them do. Now, some people just don't seem to have any problem with them, and others, you just look at them cross-eyed or something, and they will start hurting. And you'll find that TMJ cases run in families. People just seem to inherit bad joints. Your strap goes across this area right in here, and the two joint spaces, the upper joint space and the lower joint space, are there all the time. Now, when you open your mouth, now the condyle will come out and maybe out as far as this, you see. And that's the way we tell with these transcranial x-rays. And now we've got these more complicated and much better ways of telling where the disc is and all this. But the jaw will come way out here, and this strap is supposed to kind of stay with it, you see. It's attached out on the front of this and attached in the back up here. Now, as you open and close, the strap or disc stays on the head of the condyle. You can kind of see that as it goes. Now, you get hit in the jaw real hard. Sometimes it puts so much force on the disc right in here, it will pop out in front. In fact, that's where it goes most of the time. It just pops out in front of the teeth. Let me go back. I'm going to have to erase that and then come back to well, I won't be able to come back to that drawing. It just goes away. But anyway, this is I'm going to have to cut this lecture short on this, or it'll take more time than we've got to show you this stuff. So I'll come back and try to fill that in a little later. All right, so I get the patient with this splint in their mouth, and actually Charles has taken them and examined them and everything, and he's figured out where the jaw has to be for it to be comfortable. Now, and you can, if you're out there practicing or looking moving your jaw up and down. Now touch your jaw, your teeth together, and I'll bet you that's not where you chew. Most people will bite and they go backwards when they bite. And if you have a big backward slide or a distal slide when you close together, you can have TMJ problem because you're shoving the head of the condyle back into that retrodiscal tissue. All right, Charles is taking this person. If they click, that's pretty easy. You can figure out where you have to put the splint. In other words, you want to get it out to where they don't click. In other words, the disc comes back up on the head of the condyle. And now if you keep your jaw in that forward position, don't go back past it, it'll stay up on the head of the condyle. But if you chew all the way, you'll hear a little bump and the thing will slide off. Now when you open your jaw and come on further out here, it'll make a click somewhere along in here, and then it'll fall off back in here as it goes together back here. Now if you get a hold of a patient and they go way on out here before it pops on, then that's not really good, because the ligament on the disc is stretching so far you can't hardly get it back on. So you have to treat a lot of people off the disc unless you can go like Dr. Larry Wolford. I just heard this last week, and I've worked with him over the many years. He has a deal for going in the back of the condyle with a little pin, like he drives in there or screws in there, and it's got 2 sutures on it, and then he gets the disc back up here and sutures it with each of those sutures real good and stout, and he gets the disc to stay back up on the head of the condyle. Now that's a big improvement, and whenever he does orthodontic surgery, his results of it are much better if he gets the disc back up on the head of the condyle than it is if he just leaves the disc out here and sets and fixes it up and has the head of the condyle just rubbing against the bone and the fossa. His results are not near as good. So he's made a big contribution to this area of problem that we have. All right, it's going to be mixed up here and be hard for you to understand what I'm talking about. All right, Charles knows where to put this thing. He's figured that out, and he builds this splint, and he makes a splint that person cannot get behind, so they can chew up here. They have to chew in this area, and when they do, it slides their jaw forward. So their jaw stays forward all the time. It never goes back. Now he puts one of these big ramps in to start with, and they have to sleep in this thing and everything. Now after they get going, he puts a lower one in there, or maybe he does it to start off with, or he did. Then they can keep their jaw forward because they want to. It feels better. When they go back, it begins to hurt again, see. So they've got to keep it in this area. So I never did like the lower one, so I used an upper one with a very small ramp that they would wear in daytime. That would keep their jaw forward. And then at night they put this big one in, so they couldn't possibly get behind it when they're relaxed. And that if they get behind it and chew back here, they'll let you know, because it hurts bad. You know, it really gets hurty. Well, we better get on here. We got already 19 minutes in this thing. All right, here, when we come out of, he sends them in here, and they're in this disc. We have to take them out of the disc now. I've got to do away with this thing, but I've got to keep their jaw closing in the same spot it is while I move these teeth around so that the teeth can interdigitate, so that they'll chew and they'll stay in this position, and their teeth will interdigitate, and you get them chewing in there and just staying in it, and hold them there with this type of ramp. So we'd have a ramp on their retainer, and a big one at night, and sometimes a small one during the daytime. So doing this work for people who do temporal mandibular joint work, you either learn a lot about it or you're going to be in a pickle. You have to know something. Finally, Charles got his health as bad, and I did all the orthodontics in the orthodontic and TMJ work in our practice, and that got to be quite a bit. And I just learned how to do this over about 20, 25 years, or maybe a little less than that. All right, let's go on here. So we get them in the splint, and we've got to come out of it. So we're going to take this splint apart, and we're going to make it in about 2 pieces or 3 pieces. We'll have to have a ramp on a retainer, which let me go ahead and show you that. Now this is a ramp that they wear when you take the splint out. Now this ramp will keep their teeth forward. You see this? They're going up here. They bite down here, but they can't close until they get their teeth up here. So for them to close, they've got to put their teeth back in that same position. Now we'll have to make a big one of these for at night and a small one during the daytime. Now in the area of the arch, in the bicuspid area, we'll have to cover those teeth up, and then at the end we leave the second molar exposed, so that it's going to have a space between it, so it will erupt together. Now let's look at this young lady's face. She's pretty serious right there. Well, she was all the way from Wichita Falls. We were in Hearst, but she was sent here by somebody that knew about Dr. Holt, so she came down. Now she has some real problems. It's not just the simple thing of having to bring your jaw forward. This young lady is going to college up there. Her father is a dairyman, and he's not well, and so she's out there managing milking 400 cows. Man, if you can think of that. You got to get up early in the morning to get these cows milked. Now she had help, I'm sure, doing that. But this young lady is about 21 or something, and she is worked down, really. And if this work is stressful for her. I sat down and talked to her maybe 20, 30 minutes, and I found out a lot about her life. I mean, she's trying to get through school and do that, and she's trying to keep this dairy running, and she probably has a boyfriend or two that she's got to keep separated, or there's all kinds of problems come up with people like this, and she's hurting. I mean, she's having trouble, and now she smiles. She's quite a nice looking young lady, but boy, that's more the idea you get about her when you first see her. She's serious, she's worried, and she's got this TMJ problem, and that just adds to all the other load that she's carrying. So you've got to feel for this woman. And she smiles, but she's really under stress. So anyway, Charles put her in this splint, brought her jaw forward. That gave her enough relief and we talked to her about getting rid of some of these cows, or getting somebody else, so she wouldn't have to be out there all the time. I mean, early in the morning, late in the afternoon. milking these darn cows. I mean, that is a job. And so, anyway, she was wearing this upper splint in the nighttime, and she wore this bottom splint in the daytime. Now, Charles, you got to make these darn things. You got to put these clasp on them and stuff. I never did like. I had a harder time keeping the jaw forward in a lower split, so I just made 2 upper splits and a ramp on each one of them. Small one on one and a large one on the one they sleep in at night. Let me go back here. Yeah, I've got to erase that. Okay, that's her splint. That's the way it looks from the side, you see. Now, and here's the lower one from the side. Both of these, you see where the teeth are located in there. Now let me go back and show this one. And it's the same place, even though it's a little thicker, stuff like that. Now when we take this thing away, we're going to have to close this some. So I make a ramp on a retainer that comes a very similar way, like it'll be fitting up in the roof of the mouth, and it'll have a ramp on it where the lower teeth will come up and hit it and then have to slide up to the same identical position. But then, in other words, we're going to take this thing away, and you've got to do away with the splint when you start the orthodontics. And so you want to make darn sure that the person is feeling good, they're working good, you don't have a placebo deal on your hands. Take this darn thing out and go without it for a few hours or whatever it takes. And if your jaw starts hurting, put it back quick and go ahead and you figure. And if you're going along like this for several weeks, even a month or so, and you don't have any pain with it at all, this is pretty hard to say because you've got all these other causes for TMJ, like all this stress she's under and the worry about her school and whatever other worries she's got in here. You got it in, and you get rid of the pain. That's good, you know. You may not be able to with these things, so you got to kind of fix some of these as you go, you see. And sometimes it takes a long time to get a person out of pain. You got to do away with these stressful things and then keep them in a good jaw position. And that takes a while. In some people, it's very difficult. And we treated a slew of them, and I don't think there's any one that we didn't help a lot. You know, some of them we got them completely over it, but it's you got to listen to them and talk with them and let them talk to you. Let them tell you what's wrong if you want to get that done. All right, so we're going to take this away. We're going to put a ramp on a retainer that's sitting in here, and the teeth will bite down, and so it'll be like that. And you got to make the top of this ramp where they cannot get their bottom teeth back past this and bite in this area right here. Boy, that'll drive the jaw back and give you a total fit. So we'll go there. Now I use 2 upper ones. Charles uses a lower one. I think I've got it. Here's the lower one, and it's holding them in the same position, you see, and so they can get around during the day and talk, and we like for them to eat in this thing. It's hard to do, but if you eat, you need to hold your jaw forward and just chew real lightly. If you go back and say you close back here somewhere and you bite and it shoves your mandible back, then you're going to damage it some of the time during the time you're eating. So you try to keep it in if you possibly can. But it's tough. I've tried just use them myself just for the heck of it. Just to see, okay, here's her upper and her lower splint, you see. So when we start orthodontics, these go. You can't use them, even though you may have paid a lot of money for them. But what you pay for is the knowledge to know how to make this blooming thing and where to put it and all the jaw positions and all that goes in there. You could give people all that stuff and they couldn't do it at all. Alright, so here we are. We've got our jaw where we position it. This is her jaw position that's comfortable. Well, it's not even touching back in here. So we've got to put this ramp in behind these upper teeth now that makes her bring her jaw to this position. Now you come back and when they're biting on this ramp, you put some acrylic, I get that triad acrylic, and etch this and cover these teeth with the triad acrylic back in here, so that when they bite too, they've got support back in here. These teeth are touching your ramp. These are touching this bonded block. But your second molar is free. It's floating in the back here. Now you go until the second molar will erupt up into the position here. When it gets to where it touches back here in the back and is taking the load, then you take this part of the splint off. You take that portion of, the splint's gone already, but you bonded this on the teeth and you take that off, and now the second molar is free to erupt. It's holding everything up. Then these teeth will erupt together. So this gets complicated, and I didn't tell you this is. But if you're doing orthodontics and you're going to run into somebody and you're going to treat their TMJ, and you don't know how to do this, you're lost, man. I'm telling you, you're lost. You got to learn how to do it, and you don't do this on all your patients. And a lot of times on kids or young people, a lot of orthodontists don't have the foggy idea of how to do that. That's an actual fact. Now there's some good ones that are doing it and learning how to do that. They try, but they don't have time to teach them how to do this in orthodontic school, or not fully. And all of them I know because I've talked to them and worked with them and stuff. Okay, now you can see where you've got to hold it. So to keep that jaw position, you have to put that little ramp that we showed you, and then you have to have posterior support. You can't bite up here, and people don't have any idea about the mechanics of how the mouth, dentists, now the muscles are even back behind the back teeth, and if you bite up here with 10 pounds of force, you probably got 20 or 25 or 30 pounds back here on the head of the condyle. The condyle and the teeth are the only thing that are taking the load right now. See, I don't mean to get riled up with you, but so many dentists, orthodontists, and even old surgeons, sometimes they do not understand fully the mechanics of what's going on in here. All right, so that's that way. The teeth can be straight. Now you can be straightening all these teeth while you're doing all this other stuff, see? So when you take an actual case, now this case got pretty straight teeth, but I've gotten all kinds of, adults, older people, 40, 50, 60, 70, with TMJ problems. I've even done some 80-year-olds, you see. So you got to come in here and devise all sorts of ways to line them up, close space, and do all these things while you're doing correcting the TMJ problem. Catch myself here. I sometimes say gosh, you can't do this, you know. It's kind of feeling like an orthodontist. I want everybody that's doing orthodontics that wants to learn something about it. Now this old, to me, is kind of, I don't appreciate this quickie stuff that they're trying to do now. They don't know anything about uh, connecting this thing up and really doing orthodontics properly. Now this is coming along pretty good. This one looks like it's almost finished. Now we're coming along. Let me shut this thing. Okay. Okay. Now we're putting the braces on. We've got this little ramp in the front, and we had this pad back here, and we got this free in the back. I don't see the pad in here. Maybe we've skipped some part of the treatment here. But anyway, that's what we normally fix those pads back there. If your jaw, if you just have them biting out here and nothing till you get back to the condyles, you're going to put tremendous load on those condyles and the fossa. Well, here is the pad. Alright, so we put this acrylic pad on here. These front teeth are hitting the upper ramp that we've made. Now we've taken the splints that this young lady was wearing, done away with them, but the jaw is closing in exactly the same place right here, and these teeth are taking the load just like they were in the splint, and this tooth is free. It's the second molar. It's absolutely free, and so it will erupt up and come in contact with the upper molar. When it gets to where it takes enough pressure back here, then we can take this off. Sometimes I take one side off and leave the other side. If it's tender joints and they're very touchy and everything, we'll just take one off. And you can go in and grind one down and then grind it down again. But you can spend all kind of time doing that. Now you can move these teeth a little bit, but not all that much while you've got them under this. So we're going to take this off one and then take it off the other one, or sometimes if things are going real good, we just take it off of both of them. Now this tooth is holding or giving us posterior support, protecting the jaw joint. You see, when you bite down, you take a load here rather than up to the condyle. See, I hope you can decipher what I'm trying to teach you or what I'm trying to tell you here. It is not simple stuff. Alright, so we go through this, and there's the ramp on the upper, and we'll keep changing those around until we can move the teeth where we want to correct it. Now that's the upper ramp again. There we are, and we continue. We're letting this tooth erupt together back here in the back. We're taking it off the lines. I'm going to have to rush through because I've got to finish these two. Now here's this little piece in here, and these are teeth coming together back in the back, you see. And as they get to where they are taking the load, then we'll eliminate this. Then this will hold it up back here. These will come together here. And while that's happening, we have moved this into position where these are interdigitating, or we're holding it in the place where it had to be to keep the person comfortable. Okay, maybe this is where we've finished. I don't know where this is where we finished up. Maybe it is. So we've got her in a good class 1 relation. Now her jaw is in a position that is comfortable. It's interdigitating. Now we can move these teeth back and forth. It'll take me a while to to show you how to do that. It's not simple. Okay, now this is finishing. We've got her in this. This is still back in the finish. When she bites down, she slides up to there, and she's comfortable there. And she, even with the dairy, but we've whittled this dairy job down, and university had her stopped taking some courses and just kind of unload herself. She's run the limit. Now they've got the blocks. Okay, I got to cover her joints. Now when we started the case. This is the ear. Here is the condyle sitting right in there. This is the fossa. Something like that. But when it's this close, she was having trouble. I mean, it was squeezing the retrodiscal tissue too much. It's not an accurate deal. You're looking through with this 2 surfaces, but it's a 3 surface thing, so this thing may be actually touching back in there. You can't tell on this. Now here is the same joint. That's the, it just says start. I can't see whether that's the right or left, but anyway, alright, I guess it was the left, because this is the left joint with the splint in. This is the splint is in here. So the splint dropped this condyle that much further forward. In other words, your retrodiscal space back here is at least twice or more what it was. Here's your ear again. And so we move this condyle out here. So we hold it here with a splint. She has no trouble. She can put up with the dairy, the stress she has, as long as she's got some space back there in the back. That's helping her a lot. And now we try to unload her in other ways too. The trauma could, arthritis, stress, there's all kinds of things take place in giving you a TMJ problem. Alright, we go from the splint in. Now we open the mouth, and you can see the condyle way out here. See, that's the way you follow the condyle. You had 3 places in there. That's a pretty good way to kind of see it and take care of the jaw joint. You see where you're going with it. That's open. Now, alright, we go that way, and now we go into regular orthodontics. We put these other things in, but we don't have the splint any longer, but we still got the condyle out with this much space in the mouth, you see. So we're okay, everything's going good. Now this is the other side, the start, where it was close. Here's the ear again, and the condyle sitting right in there, but a very close space in here. And you can't tell exactly, because this may be rounded or something. So this is just a 2 surface. I mean, we can't see around this thing. With your CT scans and things, we can get a much better view than this. But like when we did this, alright, this is a right to splint in, and this was in 95, 8/14/95, and the splint in, brought it out here, and that's where it was when it started. We put the splint in and went out here, see. Alright, we open. It's a little fuzzy picture, but you see where the condyle goes out there. Let me take that off, and you can see it's not just plain as a nose on your face. A lot of times you gotta be used to looking at them in good light and everything. Now, after treatment or putting them in, taking them out of the splint, putting them in the deal, we still had a good space back here. And so as long as you kept it in this position, and it would go way out here somewhere when it opened, then you were okay. This is the ear. Alright, this is her teeth. Now this is where she had this lower splint on. You see, I don't use any clasp on my retainers at all. Now that goes on. There's where we finished up the case. Okay, we get her comfortable. So you see this molar now is taking load, so we're going to take this off there. Let me go back here. I don't think okay, I'm going to try to hurry on through this. There's her upper ramp, you see, on the retainer, and we will continue this with our retainer after we take all these braces and everything off of that. We will continue. As far as I'm concerned, the rest of her life, she'll have to wear some type of ramped bite plate type retainer to keep her bite from deepening. Everything. She'll have to wear that for a long time, or really the rest of their life. They can sometimes take it out in the daytime, but wear it a good portion of the day. Now there are the two type of retainers, except on our finished retainer we'll have a wire going around here. But see, this one has a ramp that goes from here to there. This one's here. Now this one you'd wear at night, just in case your jaw gets really relaxed. You don't want to bite back here because it'll shove your jaw backwards. I can see why this discourages people that are doing orthodontics from trying to do TMJ stuff, because it's complicated as heck. Alright, here we have this young lady. We got her comfortable. We got her fitting up there correctly, and we put her in retainers. And you got, let me see, when that was 96. So we take her out of that eventually. There we still haven't got. In other words, I did do one side and didn't come back and did the other side later. See. Okay, that's all the information I have on that young lady. We took a lot of pictures on her for a while, and I kind of got lax on it, but we finished her up, and she was happy, and sent her back. Well, she was driving back and forth between Wichita Falls and up there at their dairy, but we kind of unloaded her, and then we put her jaw in a good, comfortable position, and she got all right, did okay. Okay. Now here is another one. I won't spend much time on this if you stay with me a little longer. This young lady had a beautiful gal. Her and her mother would come in, but she's class 2. See, she should be down. This jaw to be out something like that, you see. But she's got a TMJ problem, and she's a young person. And here it is, 1987, and this is a class 2, division 2, and boy, it's a class 2. And this cuspid's in the wrong space. You need it back here. See, this bicuspid, this goes back here, this goes back here. This whole thing goes back, and this goes forward, see, enough to where it'll correct this interdigitation. Now, she had a heck of a TMJ problem. She bites down here, and this makes her jaw go backwards. And she pushes backward on the condyle up here, and it squeezes the retrodiscal tissue, and it hurts like the devil. Now she's in here to get something done. All right, I look at this, and she's got a click. She hasn't been in this happening too long. I don't know how the devil she got these teeth back in there that far, but she does. Now, and I sat down and talked with her, and if you're going to do TMJ work in orthodontics, you need to get the TMJ settled and then start doing the orthodontics. But in this case, I had to violate what I had, because for me to get her where she wouldn't click, I had to have her lower front teeth would be out here somewhere. And that's a mess. And you have somebody, you have to stick their lower jaw out and have their lower front teeth come over their upper front teeth. That just doesn't cut it too good. So I talked to her, said, well, you're hurting, but can you stand to let me work on you for about a month or 6 weeks or maybe a little bit longer and get these teeth out of the way? Now, you think orthodontics is bad, but Farron McCarty, and a person was in my class one time, said, I was at Farron McCarty. They're from Alabama. I think Farrah's dead. I don't know whether McCarty, whatever. He said, I was at their course one time, and they had a lady that came in from up north somewhere, was in terrible pain, and Farrah set that young lady down and told them that she didn't care. She could pull all of her teeth, do whatever that she had to get out of pain. Farrah set her down and ground these teeth off, deadened them and everything, did root canals on them, ground them off, gonna come back, crown them or something later on, sent her home, ground them off, and the lady came back the next morning, hugged his neck, said it's the first time she'd slept. I mean, and the pain was gone. In other words, he got the thing out of the way up here and let the jaw come forward. And that, I thought to myself, my God, why don't you learn a little orthodontics? You can do that so nice. Now, so that I said, let me work on you for just a few weeks here, and I'll get you out where we can bring you out where you don't have to be out here. So you don't have to have your lower front teeth in front of your upper front teeth. That's what I'm trying to say. Now, so other side, same living way. These teeth are tucked in here. You can hardly see the bottom teeth right here. All right, so we rig her up, and her lower teeth look fine. I mean, but they're being shoved backwards, you see, by those upper front teeth. That's crowding the condyles, and condyles are crowding the retrodiscal area, and so you got TMJ problem. To me, this one was so obvious. I mean, it's just hitting you in the face. You know how to do that type real easy. All right, these teeth were out here, these were back here, and so my thing would be to move these teeth forward, the first thing, and solve this and get it out where I could bring the lower teeth out here somewhere, and these teeth would be out in this area, see. So that was what I was shooting for. But I sold her on the splint. I had charges so much. I didn't charge all that much. I think it's about $600 or $700 to treat her TMJ, and the rest of the fee was the orthodontic fee, see. So anyway, I went in and we rigged this up. We put an intruding wire and came down and hooked it to these teeth, and just put a regular wire in here on the rest of them. Well, I'll just show you what we did right here and try to get this over pretty quick. And we're also going to close this up, see, We're going to push these down and level this arch out. This is the inside out. All right, that's it. This is 12 patients of 87. In other words, December, when we put all this on her, now we're going to hope to move these teeth out here, see, and free this up where the lower jaw could come forward, and where we could put her in a splint, bring her upper teeth would be out here somewhere, and her lower teeth are going to be here. And we couldn't do it with these teeth like that. Well, we could do it, but she would look terrible. There's the lower teeth. All right. She agreed to just give me a few weeks here. If I could get a month and a half, I thought I could get these teeth far enough forward right here. So I put this intruding arch, and you should learn how to use that thing. It goes up like this, you see. I brought it down, here it is, and tied it to these central teeth. I ran a little wildcat wire, any kind of flexible, 016 knife tie would do fine. Work it through here on these teeth. So we got this wire and this wire picking these teeth up. And this is 12, 28, 87. In other words, in about 2-3 days, we're going to be in 88, you see. And so we rigged that thing up. I used to kid some of the people in the lecture. I said, well, we put this omega in here that creates an electric curve that makes these teeth move a lot faster. I'd be surprised if that's what it is, but just joking with them. I just made it too darn long, so I shortened it and put it in there. All right, so here it is, the couple last days of the year, you see. And this wire, don't forget now, it's way up here, and we're pulling it down. It's not a big wire, but it has a constant force. This one has a little bit of force on it, bringing those teeth up, but not all that much. All right, there it is. This is 12, 28, 87. Now I got her back, and it is 3:15. I saw her in between this. I didn't don't wait that long to see them. That's March the 15th. In other words, we had January, February, and half of March, you see. So 2.5 months I had her in there. And that during that 2.5 months, these teeth moved from where you saw them a while ago. I didn't cover them up on purpose, but you can see the gingival tissue came in. They weren't all that terrible sore, but this is one hell of a lot better than grinding them off. I'll tell you, it is much better. And if Farrah and McCarty, if they had known a little orthodontics, they could have treated people like that, you see. They knew what had to be done or needed to be done. They just didn't know the best way to do it. And I hope that many, many dentists will see this and will learn how to do this rather than what Farrah and McCarty were doing. Well, in 2.5 months, where was my TMJ problem? Well, it happened just like Farrah's did. The girl didn't have any TMJ problem, and I'd already sold her this splint, and I didn't know what to be honest way. I treated her TMJ, so I put her in a splint and brought her out a little bit further and kind of helped it a little bit, but that was the way it went. Now, she is a beautiful girl, and we had opened this bite that much. Now I went back and put something and started bringing these down too. And now we got a long way. We got to bring these teeth out till they're torqued properly, see? So there's a lot more to do here in this. And so we're just getting into the case. So this is the 15th of March, 2.5 months after I put this thing on there, in 2 days. Okay. All right. Now, I put the splint in there and brought her all the way and let her wear that for a while, and then we take that out. But we had these teeth lined up like that. Now we're getting the torque in them good, and this is coming out. The TMJ problem has literally gone away. Now you see how it pushed this tooth backwards and probably exfoliated it a little bit while it picked these teeth up out here. The load to do that came from here, right here. If she'd chewed hard, it wouldn't have moved as much, but it did move some. Now, I did not kill this tooth right there. I think that tooth looks like it's dead there. I don't know what it was. Now here's the splint. It just showed us again where we wanted to go, and she was comfortable out here and all this. So we took her out of this, and so here we are. So we've got an intruding wire on the bottom. See, it's way down here, so it's bringing this down. This is looking pretty good now. So we put a little curvature in this arch. See, and it'll pick these up and come down with this. Now, this girl was really pretty, and she was in love with some guy, and he was going to Florida, or going to be in Florida, and her mother didn't want her to marry him, or didn't want her to leave or quit or anything. And so we had her in the middle of these darn braces, and we had her TMJ problem solved. In fact, we had the darn case solved. It was just a matter of finishing it out. There was nothing, would be nothing to it. But she was going to Orlando, Florida. Well, I looked up, and I had not treated, but I had a student who was very good, had been through all of our lectures and knew how to do orthodontics, and he was in Orlando, and so I sent her to him to finish. I never heard any more. He wrote me back and everything, but I never heard exactly how it went. But all he had to do is kind of level this out a little more, level this out, and had fix this thing right. We had our TMJ problem whipped, and we had the orthodontics whipped when she went off down there. So that was the end of that patient. She left, and her mother wasn't too happy with it, but it worked out quite good, and thank goodness I knew somebody where she was going. Well, I already got it leveled a little bit before she left. See, these are just about to contact. These need to go down just a little bit more. Got too much curvus fee in that lower arch. Now that tooth wasn't dead. It's fine. Everything's going good. And we'll bring this together and bring those teeth. We'll hook on to those later. The wisdom teeth look like they're just now getting in back in the back. Okay. All right, I'm going to finish this here. That's over an hour. I'm sorry that it went so long, but this stuff is hard to understand. It's hard to lecture on it and get where you can come in. Maybe you can decipher this and learn how to do this, but this is a tough part of orthodontics. And I'll shut up here.